Depression. Etiology and psychopathology. Impaired neurotransmission in depression has been explained by the catecholamine and indolamine hypotheses, i.e. low mood is associated with reduced synaptic noradrenaline, NA, or 5-hydroxytryptamine, 5-HT or serotonin. Reserpine, a monoamine-depleting drug, can cause depression. Conversely, tricyclic and monoamine oxidase, MAO, inhibitor antidepressants increase the synaptic availability of NA and 5-HT in the synaptic cleft. However, there is a delay between the antidepressant-induced rise in synaptic NA and 5-HT in an individual and any improvement in mood. Furthermore, depressed patients do not have decreased levels of NA, 5-HT or the metabolites of either in their blood, urine, or cerebrospinal fluid. There is an excess of 5-HT reuptake receptors in the frontal cortex of people who have committed suicide. Some common exogenous causes of depression are shown in Table 26. Vulnerability factors in women include being responsible for the care of 3 or more young children, lack of a confiding relationship, lack of a job outside the home, separation from their own mother before the age of 11. These vulnerability factors sensitize the individual to major adverse life events that are characterized by loss or threat of loss, e.g. redundancy, or physical illness. Other etiological factors include the following. Genetic. Identical twins reared apart show 60% more concordance than dizygotic twins. Brain physiology. Decrease in rapid eye movement latency. Endocrine. Loss of cortisol circadian rhythm, i.e. overactivity of hypothalamic pituitary adrenocortical system. This might be primary or secondary. Psychological. Learned helplessness, based on the model of harnessed dogs subjected to recurrent aversive stimuli who become apathetic and fail to escape when restraints are removed. Epidemiology. Of the general population, 5% will experience an episode of moderate to severe depression. Prevalence is 2–3% of men and up to 9% of women. It is more common in lower socioeconomic groups because of chronic adversity. Clinical presentation. NB. The commonly seen mood disorders are depression or bipolar disorder. Depression is much commoner than bipolar disorder. Bipolar disorder, there are episodes of persistent lowering of mood interspersed with bouts of sustained elation and overactivity. Depression, there are only downward mood swings. Common. A mixture of psychological and biological symptoms present most days for at least 2 weeks, Table 27. Patients may be agitated or retarded, Table 28. Uncommon. Psychotic depression. Depression can be of psychotic intensity with delusional convictions of disease, putrefaction, poverty, contaminating others, or causing evil. There may also be hallucinations, especially accusing or derogatory voices. Seasonal affective disorder. There is a female-to-male ratio of 6:1. Onset is in the mid-20s. Depression tends to occur in the winter months and is often accompanied by oversleeping and overeating. It can be treated with antidepressants and phototherapy, which artificially lengthens the day and optimizes biological rhythms. Recurrent brief depressions. Bouts of brief, 2 to 5 days, but intense depression occurring every month or so but not related to menstruation. NB. Anxiety and depression often coexist. Treatment. Treatment should be both psychological and pharmacological. Psychological, cognitive behavior therapy. Pharmacological, antidepressants. Add antipsychotic drug for delusions and/or hallucinations. Electroconvulsive therapy in very severe cases. NB. Exercise caution when using antidepressants in bipolar affective disorder, there is a risk of inducing mania. Antidepressants. These tend to be more effective in severe depression and where biological symptoms are prominent. Tricyclics, e.g. lofpramine, less cardiotoxic, and amitriptyline. Selective serotonin reuptake inhibitors, SSRIs, e.g. fluoxetine. Combination reuptake inhibitors, e.g. mirtazapine, venlafaxine. MAO inhibitors, these inhibit the reuptake of NA and 5-HT, thereby increasing the amount of available neurotransmitter at the synapse. NB. Management of severe depression. Assess the patient for suicide risk. If the risk is high, then admission to a psychiatric unit is indicated, if necessary under the enforcement of the Mental Health Act. Social isolation, severe self-neglect, and failure to eat or drink also require hospital admission. Mobilization of support from carers and mental health professionals is required, especially community psychiatric nurses. MAO inhibitors. These carry a risk of tyramine response, cheese reaction, which causes a dangerous rise in BP. They are also incompatible with opioids, especially pethidine, and with sympathomimetics. Tricyclics. The side effects of these include anticholinergic, e.g. dry mouth, blurred vision, constipation, ileus, precipitation of glaucoma, urinary retention, and delirium in the elderly. Alpha-adrenergic, e.g. postural hypotension. Cardiac dysrhythmias. Lowering the seizure threshold. Cardiotoxicity in overdose. Weight gain. Sexual dysfunction. Selective serotonin reuptake inhibitors. These have fewer cardiovascular effects than tricyclics and are less sedative. They also have no anticholinergic side effects, but can cause gastrointestinal problems, agitation, insomnia, and headache. Tricyclics and SSRIs are probably of equal efficacy. In depression of psychotic intensity, an antipsychotic should be added to the antidepressant. Electroconvulsive therapy. This is the treatment of choice in severe depression, refusal to eat or drink, grave suicide risk, failure of other treatment methods. NB. Electroconvulsive therapy. Contraindications include raised intracranial pressure, a recent myocardial infarction or cerebrovascular accident, or a recent ventricular dysrhythmia. Electroconvulsive therapy is applied under general anesthesia with muscle relaxants. The usual course is 6 to 8 applications, with 2 applications per week. Major risk factors are those of the general anesthetic. Side effects include headache, transient and persistent memory problems, seizures between treatments, delirium in the elderly, cardiovascular complications. Prognosis. Most episodes of depression remit within 6 months, although 15% of sufferers experience chronic symptoms. There is a high risk of recurrence if recovery from a particular episode is incomplete. The risk of recurrence increases with age. Mortality due to suicide is 15%. Prevention. Cognitive behavior therapy reduces the risk of further episodes. Also consider the continuation of treatment with antidepressants and mood stabilizers.